Hey, this is Maxfield with MedSchoolCoach. I'm a tutor for USMLE Step 2, 3, Complex 1, 2, and 3. Today we're going to go through a question together, dissect it, pick out what information is useful, how to get there efficiently, and then learn as we go. So the question, a 64-year-old woman comes to the emergency department with a complaint of shortness of breath. The patient has a history of chronic tobacco use, diabetes, congestive heart failure, and hypertension. The patient's medications include albuterol, lisinopril, metoprolol, aspirin, and metformin. The patient states that over the past few weeks, she has become more short of breath, and she has recently begun to sleep in a recliner due to an inability to lay flat. The patient's temperature is 98 degrees Fahrenheit. The blood pressure is 91/58. The heart rate is 110 and regular. The respirations are 23, and the oxygen saturation is 90% by pulse ox. The physical exam reveals bibasilar rales and diminished breath sounds at the lung bases, and a plain film is provided. What is the most appropriate next step? So looking at this vignette, we have a couple features that are going to help us decide what's going on with this patient. But the first thing to do is just go to the last line. In this case, what's the most appropriate next step? So even without looking at the answer choices yet, we see that this is kind of an open-ended question. It doesn't help guide you into whether you're going to be addressing the management or trying to assess the diagnosis of the patient. But one very useful piece of information is that an image is provided. I think it's definitely worth your time to make radiology images, dermatology images, and endoscopic images even a strong suit for you, because there isn't a whole lot that they're going to show you. And if you master these, you're going to be able to save a lot of time on the exam. So with that in mind, let's just move forward and take a look at the image to see if it complements just our gestalt from looking at the vignette. So here in the image with the plain film, we can see some perihilar fullness. We see blunting of the costophrenic angles, although it is a bit underpenetrated. And then we do see some pulmonary edema and increased vasculature as it ascends cephalad. So all of this should help give you something in mind, because there's some things we do not see. We don't see a lobar consolidation. We don't see a clear X-ray like you might see with a pulmonary embolism or something along those lines. But we do have something bilateral with perihilar prominence, some cloudy interstitial pulmonary edema, and then potentially blunting of the costophrenic angles. So here, looking at the question stem itself, 64-year-old woman, we're in the emergency department. She has shortness of breath. She has a lot of comorbidities that could contribute to shortness of breath: chronic tobacco use, and then subsequent COPD, diabetes, congestive heart failure, of course, hypertension, and so she also has risk for coronary artery disease as well. She's on medications: albuterol, lisinopril, metformin, metoprolol, and aspirin. This shortness of breath is somewhat progressive, and then she has dyspnea, which should take you quickly down to congestive heart failure or COPD. She's afebrile, which takes you away from infectious causes, even though in the real world we may see people with infections in the absence of fever. For test-taking purposes, they're going to try to give you a classic presentation. We see that her blood pressure is borderline. She's tachycardic, tachypnic, and she is hypoxic. And then using what we saw on the previous plain film, complementing the decreased lung sounds, both bases, this combination, especially in the absence of wheezing, it's very good for congestive heart failure. So even before you get to the distractors and answer choices, ideally, when you're going through a vignette, you should let it guide you and have at least 1 to 2, maybe even 3 things in mind that you feel like are going on with this patient. So now let's look at what they're asking us. So what is the most appropriate next step? So moving from step 1 to step 2, and then also continuing with step 3, they get away from just asking you straight first order questions. They move forward with giving you a presentation, assuming you know what the patient has, and then asking you to either answer diagnostic questions, treatment questions, and in this case, it's a treatment question, assuming that you've arrived at the correct answer. So heparin drip, clearly they would be looking for some sort of blood clot. What the question stem lacked: history of recent travel, endothelial damage, history of blood clots, and a progressive onset shortness of breath. All of that goes against a blood clot. IV furosemide. So furosemide, being a loop diuretic, would be a great symptomatic treatment for acute decompensated congestive heart failure, which is what a lot of that question stem led us to. So we'll star that for the moment. IV ceftriaxone. So again, the patient was afebrile. It didn't say anything about production of cough, change in sputum production to purulence. if the patient had COPD. And so in this case, this seems unlikely. Albuterol and systemic corticosteroids, again going towards a COPD exacerbation, but in this case, without the indication for antibiotics. That seems unlikely. And then oftentimes we'll get a second choice for antibiotics, in this case, hypericillin tazobactam. We didn't have any history of nosocomial exposures, and again, we're thinking congestive heart failure. So that takes us to furosemide. So congestive heart failure and how it affects the lung. So in this patient, there's some key things to help us identify what type of congestive heart failure this patient may have. And the most important feature was the presence of lung involvement. So why is that important? Because when you think of the increased hydrostatic pressure, assuming that the left ventricle is involved in the heart failure, we'll draw a picture. So let's say here's the heart. We're not going to do this anatomically. We're going to draw it similar to how it's set up within the system. So let's say this is the patient's right lung, left lung, right ventricle, and left ventricle. As blood enters the heart into the right ventricle, then to the lungs, and then back to the left ventricle. And then from there, it wants to go into the peripheral circulation. If the left ventricle is incompetent, this is blocked right here, and the blood can't leave the lungs effectively because of a buildup of hydrostatic pressure in the left ventricle. So if the fluid can't go forward from the lungs, the fluid is going to stay static or go backwards, we could say, and it's going to build up pressure within the pulmonary vasculature and cause a transudative fluid leak into the alveoli. This alveolar fluid collection decreases the gas exchange, and because of this, patients present with shortness of breath, and because it affects both sides of the lung and their ability to bring blood back into the left ventricle, it presents with bilateral rales, which is a distinguishing feature when you're considering the alternative diagnoses. Now, patients often can have pitting edema because that same increased pressure is then pushed back into the right ventricle, pushed back into the systemic circulation. And then if they're unable to perfuse, if enough blood is unable to get out of the left ventricle and go into the rest of the body, they may have cool extremities. Other radiographic findings may be more subtle, whereas the picture we looked at earlier had more prominent features. This one has a subtle feature of cephalization, in which the pulmonary vasculature is large and dilated, assuming that this is an upright film, just so the patient is sitting up, standing up, and despite that, the gravity isn't able to bring the blood to the more dependent areas, and the vasculature remains dilated up in the cephalad areas, similarly to how it is dilated in the caudal areas. Some other features that they might bring up are the curly B lines, which represent interstitial edema that extend to the pleural wall. We have the curly A lines, which arise out of the hilum, represented here by orange. And then we have the curly C lines, which are represented by the green arrows. And these are a little harder to see, but they do not extend either to the pleural lining, and they don't extend directly from the hilum itself. But all three are indicative of pulmonary edema. Now, the diagnosis of this is often brought to you clinically, which is why this presents as a good opportunity to test you for second and third order questions. You can use a plain film as your best first initial choice because it gives you good diagnostic information. It's cheap, it's fast, and it's relatively non-invasive. And it has characteristic features that can help you arrive at a diagnosis. Serology with a BNP, the brain natriuretic peptide, is another sensitive marker that can be used as an initial screening test at various values, and we'll talk about that as well. And then how is it treated? Acute decompensated heart failure is treated with furosemide, which does two things. One, it prevents diuresis, and then two, it causes pulmonary vasodilation that improves dyspnea. Nitrates are another thing because in addition to decreasing the amount of fluid going into the heart, that's causing it to be overdilated with furosemide. Nitrates can decrease the afterload, or the pressure against which the heart is pressing. So by relaxing or decreasing the afterload, it'll improve cardiac output and improve the peripheral perfusion. That can be done with nitroprusside, isorbide dinitrate, or even nitroglycerin drip, although the latter does not consistently produce any sort of mortality benefit. When you're thinking of treatment, however, with systolic congestive heart failure or heart failure with reduced ejection fraction as opposed to heart failure with preserved ejection fraction, They are a little bit different. So they both can rely on exercise, lifestyle modifications, decreased salt intake. But systolic congestive heart failure with reduced ejection fraction, is unique in that multiple medications have been shown to reduce mortality. These include ACE inhibitors, angiotensin II receptor blockers, beta blockers, spironolactone, and then in African American patients, the combination of nitrates and hydralazine has also been shown to reduce mortality. A newer medication, sacubitril valsartan, or Entresto, is a very unique mechanism because it prevents the breakdown of BNP, which we just talked about briefly on the previous slide. Now, BNP acts in a couple of different ways. One, it promotes sodium natriuresis through the kidneys, and it actually interrupts the renin-aldosterone system in a meaningful way. Both of these features are responsible for its improvement in patients with congestive heart failure, and also are thought to be contributory in its mortality benefit. But because it prevents the breakdown of BNP, it can cause false elevations of BNP in any patient who's on this medication at baseline. So because of this, if a patient is taking sacubitril valsartan combination, the sacubitril being the active component of this, you need to test for the pro-BNP. Now, this, if you think of like the pro-insulin level, will be a more accurate marker for BNP levels in patients in whom you suspect are suffering from an acute exacerbation of congestive heart failure. Now, for symptomatic relief that does not provide mortality benefit, digoxin. Digoxin is a very unique medication, has a lot of notable side effects, but in the setting of congestive heart failure, again, it does not improve mortality, but it does reduce hospitalizations. And then there are specific indications for medical devices in patients with an EF of less than or equal to 35%. That's an indication, a testable indication for an implantable cardiac defibrillator. And then a biventricular pacer is indicated in patients with dilated cardiomyopathy and a QRS greater than 120 milliseconds. That one I find is more consistently on step 3 material, level 3 material, but it is something that you should know. Now, diastolic congestive heart failure, the treatment is largely similar in that use ACE inhibitors, angiotensin II receptor blockers, spironolactone, nitrates, hydralazine, but in this setting, they do not have an improvement on mortality. Diuretics can be used to treat pulmonary edema. Again, congestive heart failure with preserved ejection fraction does not necessarily mean right-sided congestive heart failure. It can also coincide with restrictive heart failure diseases. And because of that, they can get pulmonary edema as well, because the left side of the heart can also be involved. And then beta blockers are also used, but specifically in the presence of angina in these patients. Cardiac rehabilitation has been shown to improve quality of life in these patients, but again, no net mortality benefit. Well, this is just an introduction to some congestive heart failure tips, tricks, and testable points. Hope it was useful for you, and we look forward to seeing you again.